I am Amresh Shrivastava and I work in assessment program which receives patients of acute schizophrenia. Today I am going to talk about psychoeducation, which is an important component of management of schizophrenia. I am supported in this initiative by two of my colleagues who work in field of schizophrenia with special interest, and I'd like them to introduce themselves to you. Yes, Coralie, please go ahead.
My name is Coralie Berlamont, and I'm a social worker, and I frequently work with individuals and their families around mental illness.
My name is Lenore Perdue, and I'm a registered nurse and a social worker, and I work in the community providing intensive case management to those who have been diagnosed with a psychosis.
We are now going to start with the components of psychoeducation. What it means that here is a potential situation that a young man has been hospitalized and his parents are distressed, and we want to give the family as much information as necessary, as accurate as possible, and as scientific as it is. And I would request Coralie to start with the presentation.
Today we want to talk to individuals and their families about schizophrenia and mental illness. We hope to be able to provide you with a toolkit that will help you succeed. Education helps provide you and your family with the power to understand and the power to conquer mental illness. It also provides you with the success to cope and to move on. You do have the ability to succeed, and we're hoping to help show you how to do that today. Luckily, we've moved forward in terms of understanding mental illness and schizophrenia. In the past, schizophrenia often meant despair, despondency, basically somebody didn't have a chance for a future. Luckily, as we move forward, we know that that's not true. We know that people do have a hope, do have a future, and do have a chance to succeed. John Nash is a Nobel Prize winner, but he's also well known for the movie A Beautiful Mind. A Beautiful Mind is a good example of somebody who has overcome schizophrenia, and it's widely known and seen throughout the world. This movie shows how John Nash suffered with schizophrenia and how he had to work to move past this illness and still succeed. So we see in the movie how he's diagnosed with schizophrenia and how he's often not understood or accepted by his peers. But John Nash knew he had something inside of himself to give to others, and he fought to give that. So he overcame his mental illness, and he ended up contributing to society.
Last 50 years, treatment of schizophrenia is revolutionized. We need to be ready to understand this and take advantage of scientific developments. Our patients who are suffering from schizophrenia whom we treat recover much better than many other chronic physical conditions like neurological conditions or chronic metabolic conditions. It is the difficulty of awareness amongst people that they fail to take advantage of a scientific advancement or treatment advancement. My first dialogue with the relatives is that there is no one to blame. Schizophrenia is an illness which is a brain disease. It is not an illness where you hold yourself responsible.
Now we're going to talk about some very common myths that are often heard. Myths are rampant throughout society about schizophrenia, and we want to talk about what those myths are and to show you that those myths are often not true. So we're going to talk about what does not cause schizophrenia. Schizophrenia is not caused because somebody has a bad parent or is a bad parent. It's just simply not caused by parenting.
Schizophrenia is also not caused by various childhood experiences. There's nothing within your childhood or your children's raising that could have contributed to this diagnosis.
Schizophrenia is not caused because someone is poor or because somebody is in a certain economical or social class. Schizophrenia affects people in all sorts of social status, economic classes. It can happen to anybody.
Schizophrenia is also not caused by laziness or desire to avoid working. Often one of the symptoms of psychosis is a lack of motivation, which is often confused with being one of the characteristics of schizophrenia, or that it is caused by that lack of motivation. It is not true.
Schizophrenia is also not caused because someone just wants to be a loner, they're violent, or they just don't really like people. You might see people act like this with schizophrenia, but it's not because of a choice that they've made, it's because of symptoms that they're experiencing.
Schizophrenia also is not made up to get attention or sympathy. The symptoms of schizophrenia are very difficult and very traumatic. No one would make up or create these symptoms in order to get attention.
And you frequently hear people feeling like schizophrenia is split personalities. Schizophrenia is not split personalities. It's nothing like split personalities, and we're hoping today that we'll show you the differences with all of these common myths.
And most importantly, schizophrenia is not untreatable. Fortunately, we've come a long way in the treatment of schizophrenia, and there is a great deal of hope, and there's a future for those with schizophrenia.
Often the question arises and families wonder, and when they first meet us, they want to know what exactly they can do now, what role they can play, and how they can help speed up the recovery of their loved one. Our suggestion is that first, we advise relatives to keep an open mind, not to go by any past experiences or the stories about others that they might have heard, and reach out to the treatment team and discuss any concerns that they have. This would be very helpful.
Have faith in the treatment team. Your treatment team is made up of experts who have chosen to specialize in this type of illness. Have faith in their knowledge and expertise, and be a partner in the care. Participate in decision making. Be informed. Do research. Family members need to know information, treatment details, and their own roles and responsibilities. The treatment team will help you to address these issues.
So there's many common questions that people ask when they come into hospital. Some of those questions are, is it necessary to be hospitalized? Can they just stay at home and receive treatment instead? How long will they stay in hospital? And will an admission make their life worse because they're cut off from their everyday normal life? People also want to know, can they stay as a voluntary patient? Why involuntary status over voluntary status? And how will this impact their life?
The first question which is posed to us, is it necessary to be hospitalized? And our response is that if there is a situation that people are available in the house to look after and care for the patient, and patient is not having any risk to himself or to anyone else, then it could be a possibility with close monitoring to do the treatment from home. But by and large, when schizophrenia appears, it appears suddenly with acute symptoms. The symptoms which are dramatic, which are very distressing. If the medical team or the physician has advised that patient needs to be hospitalized, that advice depends upon his expertise, his experience, and his knowledge about what can happen and how to really treat that patient. Sometimes we have to use the provisions of Mental Health Act for admitting the patients involuntarily. It's only done for a brief period of time where patients are not willing to stay in the hospital, and it is extremely important that they stay in the hospital and take treatment. After a period of hospitalization as an involuntary patient, the same patient can stay as a voluntary patient once he improves and understands the risk and complication and gives the consent.
Initially, involuntary status can be very upsetting for individuals that come into the hospital. They don't understand often what it means or why they need to be kept on an involuntary status. But they do have options when they are made involuntary, which we'll talk about in a little bit. But it is often important for us to make somebody involuntary to help protect them and to make sure that they're going to be safe. And it's important to have the family to support us in those decisions and to help us explain to the person why we have to do this for their own benefit at times.
The role of the family and caregivers is varied and critical, especially when the patient is hospitalized. Your loved one is going to need a great deal of support. They're going to need your concern. They're going to need you to be an advocate, and they're going to need you to be there for them. And then again, after discharge, the continued care, support, advocacy must be continued in the community. It's difficult for anyone to succeed once they are discharged from the hospital unless they have that care and support.
A major question that we get from families is, what do they do when they care about somebody and they know that they need to be hospitalized, but that person doesn't think that they need to be hospitalized? That's a huge issue for a lot of people, because often people who are suffering from mental illness don't realize that there's anything wrong. What they think is happening is that everybody else has the problem and not them. So it's pretty hard to convince them to come to hospital or get treatment. So there are options for people when there is this situation. There's not a lot of great options, but there are options to help get somebody into hospital when they don't want to come. There is the Justice of the Peace, which someone can go to if you have evidence that you've collected based on things that you've seen the person do, activities that you think are bizarre, statements that suggest a risk to themselves or others, or if they're not caring for themselves, that you can go and present this information and try to get a person brought into hospital for an assessment even if they don't want to go. Unfortunately, a lot of times people have to end up calling the police to come out and do an assessment from wherever the person is living. The police are the only people under the Mental Health Act who are able to come out and do an assessment with somebody and take them to hospital against their will. This is a very distressing situation for families because they have to call 911, they have to have the police come out, and their loved ones often think that they've betrayed them and are very hurt and angry with them for a long period of time. We hope, though, when they recover that they do see why this had to be done. There's also things like community treatment orders for when somebody is in hospital and they're leaving and we're not sure if they're going to continue with the follow-up. They're doing well, but they have a history of not always doing well after they leave the hospital. The community treatment order allows us to make sure that they are getting follow-up, and if they don't, it puts some precautions in there to make sure that they would be brought back to hospital for an assessment if there were further concerns. So it can be a good option, but again, it can sometimes feel very restrictive for certain individuals that we're talking to them about it.
All of these are effective ways to help to get your loved one to the hospital when they would rather not. But first and foremost, it's important to contact your community healthcare team. They have been the ones who have been working with you and your loved ones, and contact them. They can often put you in touch with the resources which you will need to take this further.
It is important to realize that if you are a person who has not been in the system of mental health care, or it is for the first time that you are seeing behavioral disturbance in your family, and a patient is refusing to go to the doctor or go to the primary care physician or go to the psychiatric hospital, the distress increases. And in that situation, you should be proactive and take help from wherever it is possible. There are not many logistics which are readily available. It is sometimes a struggle, But if you reach out to your friends, to the people in the community, or any social work agency or police, most often the treatment works out well and patient is able to get an assessment properly.
The Mental Health Act is a really good resource for people to review and understand, because it lays out everything that we're talking about in terms of, you know, what you're able to do and what your rights and responsibilities are, what staff is able to do, what medical professionals are able to do, and it's been created to make sure that everybody's rights are protected. Often people don't understand the Mental Health Act or don't know that it exists, and that can create, you know, more confusion for people. So if you are able to review that, then it would be helpful for you to do that. So the review board is an option for people who have been admitted involuntary. So sometimes people are brought to the hospital and the doctor assesses them and decides that they need to remain even if they don't feel that they need to. So the first form is a 72-hour form, and it's called a Form 1. So the person initially would stay on that, and then it would be decided at the 72 hours if they would remain involuntary or become a voluntary patient. If they remained involuntary, they would go on a Form 3. At that time, the person has the right to have rights advice. If you're an inpatient at the hospital, a rights advisor would come and speak to you about what your rights are. Some of those rights are that you can have a board, which would mean that if you're not able to pay for a lawyer, one would be appointed to you, and a board would proceed within about a week's time. At that board, you can go and present your case and say why you don't feel that you should be kept in hospital against your will. Families can also come to those boards to testify for or against the person. Unfortunately, it can be not the best or most pleasant situation for people, and it should be avoided if at all possible. But people do have the right to say to their treatment team that they disagree with the decisions that they're making and move forward from there.
End of the day, we feel that in our experience, the review boards restore patients' confidence in the treatment and its systems. It gives them some understanding that whatever is going on is correct, is logical, and that's the way it should be. And ultimately, it helps in the treatment, and review boards are very much one of the stakeholders and partners in the whole rubric of patients' care.
One positive thing about the board is that in the past, people didn't feel that they had the same rights that they have now. So this gives people the ability to challenge the doctor, to challenge their treatment teams, and that wasn't always the way that it was. So it is one way that we have progressed and that we have moved forward in terms of giving people their rights back. People do sometimes win boards because the team feels, the board review feels that the team does not have the evidence needed to keep them. So it can really protect people's rights if they feel like their rights are being violated.
Ultimately, what should a family do if their loved one is diagnosed with schizophrenia or psychosis? First of all, remain involved. Stay involved in their care. Attend doctor's appointments with them. Advocate if necessary. Once they're discharged, sometimes families feel that they can continue, their loved one is able to function independently, but often this is not so. It is a critical time for the loved one once they are discharged. Take responsibility. Be responsible to be involved, be responsible to monitor and to be vigilant for your loved one. It's important to monitor their behavior, monitor their symptoms closely, watch for anything unusual. Watch for non-compliance. By non-compliance, usually we mean not taking medication or not attending doctor's appointments or sometimes not attending groups. We encourage individuals to attend various support groups after discharge. And it's vitally important that your loved one continues with their prescribed medication. And be available. Be available to your loved one and be available to the treatment team if we need to confer with you. Most important, be supportive. Be there for your loved one. It's going to be a difficult time. There's going to be ups, there's going to be downs, but be there for them. Discuss their illness and discuss their future, discuss their hopes, dreams, fears, discuss them openly, be open and honest about their illness, using the words mental illness or psychosis helps for your loved one to understand that this is what they are dealing with. And again, seek information, do research, access all resources available to you.
It's important not to feel afraid of the treatment team. A lot of times people wonder, can they ask questions? Can they make phone calls? They feel discouraged that they can't get through to people right away. But it's important to realize that this is your treatment, this is your family's treatment, and you have a right to be a part of it. You have a right to have answers. You have a right for people to include you in that treatment. So make sure that you do ask and you do let people know when you're not feeling comfortable with things, and that you fight for your right to basically be involved, because you do have that right. And sometimes with the busyness of how treatment goes, people can feel left out. So that's why it's really important that you do advocate for yourself and your family to make sure that they are getting the treatment that they need.
Moreover, it's an asset if you have the capacity to understand the person. In mental health, it's difficult to dissociate an illness from a person. The two are very much within the same rubric. Therefore, goal of the families would be to restore the person away from the illness once recovery starts taking place. It's also important to realize that the behavior which the patient is displaying is part of an illness. We know that all human behaviors have connections from brain, and it arises from complex interaction of brain, mind, and personality. And in this condition, the pathology or problem which is created by the illness is responsible for odd behaviors or seclusion or aggressiveness, and relatives need to understand. Sometimes they get carried away that this is the son or daughters are doing it to get something or with a motive. That's not the case. This behavior is fairly treatable and reverses with time when treatment is complete. It is also important to realize that patients are not responsible for any of their actions, and we should not continue to blame them for their actions. Rather, we should focus on treatment, quality of treatment, continuity of treatment, and consistency of treatment.
So it's important to remember that this is a medical issue, and a lot of times that's forgotten, that it is a medical condition just like any other medical issue. And with medical issues, everybody has responsibilities and things that they need to do to make sure that they stay well. So we often try to make sure that people realize that although you can't control certain parts of the mental illness, you can control other parts. So we'll be talking a little bit more about that later, but it is important to recognize that the things that you do, the things that the family do, will contribute to whether or not the person gets better or doesn't get better or stays the same. So it's important to know what your responsibilities are with the illness.
Often it's very difficult to cope with the diagnosis. That's the first step, is accepting the diagnosis and understanding what comes with that diagnosis. And that can take anywhere from a few days to weeks to months. It is a life-changing diagnosis, and it's, especially at the beginning, no one is quite sure how it is going to change their life. And the second thing is, it's difficult to understand that this is a medical issue. Unfortunately, there are many myths about schizophrenia, as we had said earlier, but it is a medical issue, it's a biological issue, and just as any physical problem is. Accepting a diagnosis of schizophrenia can be devastating and heartbreaking, but what we're here to say today is that there is hope. We have come so far in the treatment and the understanding of schizophrenia and psychosis that we understand now the prognosis is so much greater, and there's so much hope attached to this diagnosis.
We often, like Lenore was saying, we often see with families, it's so hard for them, for the individual, but especially for the families, to really accept that this is happening for them. And that's normal to feel that way, but it's so hard for them to accept that the person that they love and that they care about might be changed forever. That doesn't mean that the person can't go back and have a good life, can't move forward with their life, but anybody who's diagnosed with a medical condition, that means their life will change. And so that's very hard for people to accept and recognize, that this person isn't going to be the person that maybe they thought they were going to be or they wanted them to be, that they're going to be somebody, you know, different, who's going to have a different life but can still have a good life. So it's very normal for people to be angry and sad, and especially, like I just said, in denial, because it would be hard for anybody to hear somebody has a medical issue that you care about. And I'm sure everybody's experienced that, hearing someone that they know, a friend, a family member, has something wrong with them, and it's really hard to accept that their life will be changed.
While all that is true, we have the good news that now early intervention initiative has provided a lot of information in terms of research and services. And there are great advantages of the programs which are conducted all over the world. The first is, if you treat patients early, and the earliest possible treatment is a qualitative program-based treatment, the overall outcome is much better. It can reduce hospitalization. Early intervention improves chances of clinical as well as social recovery. And let me also say that the first episode is the best episode to treat. The opportunity of rehabilitation and restoration of brain tissue, which is available in the first episode of Psychosis, is lost by repeated episodes. Psychosis is a very toxic condition for the brain. If psychosis persists, it not only produces symptoms, it changes the whole personality complex. Once the illness is incorporated deeply into the personality, it becomes hard for any therapy to work as effective as we expect it to work. And therefore, a responsibility on everyone is to create awareness, reach out to people, identify symptoms as early as possible, take the patient for treatment as early as possible, start medication and social treatment as early as possible. Once we have done that, there is no difference in this illness and any other illness, and outcome, social rehabilitation, employment, marriage, living with dignity, and total social integration becomes a very real possibility.
In the community, we provide treatment through a very comprehensive case management model, and that involves meeting with a case manager at least weekly. The role of the case manager is to monitor medication compliance, to monitor signs or symptoms of recurring illness, to monitor side effects of medications. The individual is encouraged to attend groups, any type of support groups that are available. The individual is encouraged to research and access, as I said earlier, any and all resources. And it really involves a relationship between the case manager and the individual and the family.
A lot of times when people do come into hospital, or we're looking at assessing them, we look at both the biological and the psychosocial issues. We frequently see the combination of the biological components, but there's also many psychosocial issues that also contribute to the difficulty people experience. We're going to be talking about some of those psychosocial risk factors later on in the presentation, but it is important to assess both the biology as well as the psychosocial issues to get a clear picture about what's happening and what we can do to help.
As I said earlier, a case management model involves a partnership with the client and their family. Providing a holistic approach to care means essentially that the individual with the diagnosis is not solely the client of the case manager. The whole family becomes a client of the case manager. And effective and successful treatment would be impossible unless the three elements, the treatment team, the client, and the family work together and maintain an open dialogue and develop a trusting relationship. And part of the role of the case manager, as I said earlier, is to monitor medication side effects. So a very thorough assessment is done with each interaction with the individual. The case manager also provides supportive counseling. Often there are many psychosocial issues that go along with this illness. It's often a time in an individual's life when there are many psychosocial issues anyway, and the case manager works to help reduce the stressors that they're experiencing. The case manager also provides education to the individual and the family and connects the clients to appropriate resources within the community. And like Dr. Shrivastava said, most importantly, the role of the case manager is to be that link and to communicate with stay in close contact with the attending physician, psychiatrist, and to keep that open communication continuity.
When somebody's a patient and they don't have any community resources, their social worker and their team can connect them to community services with case management. They'll assess what kind of needs that they have and look at what type of case manager that they would need and make referrals. So if you or your loved ones don't have anybody that's supporting you in the community, you do need to ask the team to make those referrals. And if they're not making those referrals, then they should explain to you why that's not happening, because it is important for people to have ongoing community support. There's different levels of community support available, and there's usually something that will fit everyone. And the sooner that these referrals are made, the better, because there can be wait lists. So it's important to really have those referrals made as soon as the person gets into hospital.
Coping is another important piece that we need to talk about. Like any disability, the news of psychosis or schizophrenia and the historical baggage that this is an illness which doesn't recover causes severe burden on the relatives as well as on the patients. Coping is the only option. You cannot be under burden. That's not a choice, that's not an option, and therefore you need to learn to deal with this change in your life and try to minimize its impact. And how can you do that? By reaching out for all possible help in treatment. So therefore, the first skill which we would like our patients and relatives to develop is to cope with the change that you are facing. Do not hesitate to reach out for help when you feel overwhelmed. Stay positive and optimistic. In terms of feeling depression or dysphoria, go to the doctor and discuss with the issues.
So it's important to take care of yourself. It's important for a family member to take care of themselves, and it's important for the individual to take care of themselves. So as a family member, it's important that you take care of your own physical health. You have to get regular exercise, get enough sleep, do all those hobbies. Just like what we're going to tell an individual to do, it's important that the family does that as well. It's extremely stressful to be in a situation where someone you care about is ill, and it takes a toll on the family members, especially since with mental illness, a lot of people resist the treatment and don't initially recognize that they need help. They can be angry at their family for wanting them to have this help. So family members will often feel stressed and under pressure and confused and not sure where to turn. So that's why, as a family member, it's really important that you take care of yourself as well, so that you can be there for the person that you love, and that you can be there as a strong support and to model that behavior of what they're going to need to do to stay well after they're discharged.
continue as well to plan family activities and to do the things that you would normally do. Take part in hobbies, enjoy the things that you always have done. It's really important for the individual who's been diagnosed, for him or her to feel that life is going to go on, and they are still part of this dynamic family situation that they've been part of. And and as well for the family, continue to do those things that bring joy, the things that have always brought joy to your family, especially during this time. It's important to remind yourself that this is what keeps your family together.
Your responsibilities, the responsibility of the family members, are enormously increased when the patient is discharged from the hospital. There is one set of responsibility when your patient is admitted in the hospital and you are not directly involved in observation of signs and symptoms and risk. And there is other set when patient has been discharged and you are the main contact and you are the key contact. And remember, you are the most important person in the life of this patient. And therefore, be vigilant, be available, be free in communication, and establish a rapport which is going to help.
So some of the questions that families might want to ask after the person is discharged is to see, is the person continuing to improve as they thought that they were going to? So when the person's in hospital, there should be a discharge meeting prior to the discharge where you can sit down with the treatment team and ask, what should happen now? What should we see happen? Usually at the time of discharge, people aren't at 100%. We can't keep people in hospital, unfortunately, long enough to see what the end result will be. But we keep them to make sure that they are well on their way and that they're doing well at the time of discharge. So we want to keep seeing that progression after they leave. So it's important to know, are they improving? What should we be seeing if they are improving? And to not be concerned if they're not exactly where you want them to be at the time of discharge. You want to make sure that their daily self-care is improving, that they are wanting to take care of themselves. They're getting up, they're showering, they're doing all those kind of normal everyday activities that they would have done previously. It's also important to remember that some characteristics are just their own personality. So if somebody always didn't want to do something before they were ill, they might still be a bit resistant to that. So it's just important to look for the normal everyday things that anybody would do to show that they're getting better. They might not be perfect, but they should be doing things more in an organized way and on a regular basis. You want to make sure that their sleep is going well. Sleep is extremely important. If you see any disruption in their sleep, it's really important to take a note of that, to encourage them to talk to their doctor about that or their case manager, whoever's involved with them. If you're worried that they're not going to talk about some of these things, it's important to try to go with them to their appointments and explain to the doctor, the treatment team, what's happening after they're discharged. A lot of times we get very valuable information from the families that we're not getting from the person themselves. Sometimes families end up writing us letters or leaving us voicemails to try to get us that information, and that's all very important feedback. And you want to make sure that you're not seeing any type of risk factors to the client or to anybody else. So again, it's just making sure that you're not seeing anything out of the ordinary or strange. You know, the person should be back to similar to what you've always known. So just making sure that you're not seeing anything bizarre happening, and if you do, again, making sure people know and that you talk to the person themselves too about what's going on.
And if you have any questions at all about anything that we just talked about, contact your healthcare team right away. They're happy to provide answers, to clear up some of the concerns that you have, and to provide you with guidance and direction if you need it.
So there's several common barriers to treatment. So one thing that is a barrier for people is that they often have poor awareness. So that's why we're doing this today, is to help give people awareness about what they need to do, what they need to be looking for, what their options are. But often if someone doesn't know what's happening, if they don't know what their options are, then they're going to end up back in a bad situation. So people often also don't know how to identify their symptoms. They don't know what they should be looking for in the people around them. They don't know what they should be looking for in themselves. So we hope to kind of provide that information as well to know what's a warning sign. What should I be concerned about? Because there's some things that might not be a concern. They might just be bad behavior. It might not be anything to do with their mental illness. So it's important to know which things you should be concerned about and which things a treatment team or medical professionals are going to be concerned about as well. And stigma is a huge issue that we're still struggling against because it's been a long history of stigma against mental illness, people not understanding it, people not accepting it, people not seeing it as a medical issue, which has been very unfortunate for thousands and thousands of people. And again, going back to the story of John Nash in A Beautiful Mind, that movie, just one movie, has created already so much more information about schizophrenia, about mental illness. It has shown people so many things that we didn't know before. And that's just because there was a movie that was successful, that people watched, that people got some good insight into what could happen for people, that made a lot of difference in many people's lives. So it's important to keep challenging stigma, to keep talking about it, to keep reinforcing it's a medical issue that needs to be treated just like any other medical condition.
There are several ways to deal with the stigma. And in my opinion, dealing with the stigma is a composite part of the treatment package. What is more important that you be first free from stigma yourself. If there is a negative attitude in the family members, that needs to be dealt with in the meetings with the professionals. It is increasingly important that you be proactive to get services, to get what you and your patients require in terms of medication, hospitalization, community care. Ask for it. Struggle to make it available as much as possible. The next best to deal with the stigma is your ability to identify illness early. And as we go along in this presentation, you will hear all common symptoms and identification pointers that you need to know. Deal with discrimination firmly. Do not tolerate discriminations or impact of stigma. If you allow stigma to prevail upon the treatment, the quality of the treatment and its efficacy will be poor. The best answer to deal with discrimination and stigma is complete treatment. Once you believe in the treatment and you complete the treatment, go through the process of rehabilitation and social integration, the person is same as if he never had schizophrenia. Do all those possible things and aspire for all those possible things which a normal people without schizophrenia try to do. And that is the best answer to stigma, that you are properly rehabilitated in terms of your job, your employment, your capacity, your standing, your status in the society, and your ability to do things. We hope that this will be a possibility for all of our patients sometimes.
And if you can't avoid stigma, the most important thing, again, is to remember what you know and what your family knows, which is remembering the education that we're talking about today, is that sometimes you can't stop people from thinking what they want to think, but if you know the truth and if you know the medical issues that are involved in it, then that's what's going to help you get through this, because you're going to know that people just don't understand mental illness, and that's their issue. It's not your problem. You can't make them understand. All you can do is hope that mental illness never strikes them or anybody else in their life, because otherwise they will know exactly how hard it is to face an illness.
The movement against stigma cannot be completed without your participation. You are the key because you have seen the illness, you have gone through it. Whenever your patients recover and is rehabilitated, remember there is someone out there still suffering. You have a responsibility to be active in advocacy groups and take this movement forward. Do everything people without schizophrenia try to do, and that's the answer to stigma.
So what should you be most cautious about? So during a severe phase, an episode, be aware, do not confront. do not confront the individuals. Often they will present with a delusion, and we will talk more about the symptoms of psychosis later. But when someone's experiencing a delusion, it's important not to confront. The delusion is as real to them as your own reality is to you. Do not overprotect. Often as parents, as caregivers, we want to protect our loved ones, and especially when it's our young people. Try not to overprotect. They need help, and the most important thing is to get that help, however that is. Discuss with the team the best possible approach to take. Is hospitalization the answer at this time? Can it be managed at home? Stay open and honest with the healthcare team and work together. Complete the treatment. During a severe phase, it's important to continue the treatment. If medication has been interrupted, start back on the medication immediately. Continue, support your loved one to continue to attend support groups, to attend any community resources that they've been accessing, and observe. As I mentioned earlier, vigilance is very important. Watch for signs of withdrawal, watch for signs of depression, and be aware if you notice any possibility that the individual could be of risk to themselves or to someone else. And of course support, which is vitally important. As difficult as it may be, it's important to try and refrain from negative emotions. Yes, this illness does impact not only the individual who's been diagnosed, but the whole family. But try to remain open and optimistic and positive, which is a key to getting through this. Now, after recovery from a severe episode, continue to monitor medication compliance. So by that, I mean it's important to keep an eye that your loved one continues to take their medication, continues to accept the method of treatment that's been prescribed. Medication compliance is a serious concern. Often when an individual starts to feel a little bit better, they don't feel that they need the medication anymore, and it's important, really important, to try and encourage them to continue to take that medication, that is what has caused them to feel better. Substance abuse is a concern as well. We will talk further about the involvement with the connection between substance use and psychosis. But be open again with the individual about their use of alcohol and any illicit substances. Once you develop and open that line of communication, it becomes more comfortable to talk about these issues, and it's important also not to be hard on the individual if they do admit that they have taken part in using substances. Talk about it, remind them of the risks involved, but keep that line of communication open. And finally, help them coping. Yes, you're coping yourself and developing your own coping skills, but remind them of their own coping skills and their own coping strategies, and help them to continue that. They may not feel like it. It may be difficult at times for them to remember what those coping skills are, but remind them of how well they had been doing earlier.
Next, we want to talk about understanding psychosis and schizophrenia. All patients suffering from schizophrenia develop psychosis within the beginning, and we're going to explain what that means and what it looks like.
However, it's important to remember that all patients suffering from a phase of psychosis do not necessarily go on to develop disease known as schizophrenia. Psychosis can arise because of several conditions, or it can come because of schizophrenia. So the question comes, how does psychosis differ from schizophrenia? The psychosis is a clinical condition. If it is not schizophrenia, then what this condition is, there are several possible uh, causes. Some of them are psychosis arising from substance abuse, psychosis arising from mood disorders, psychosis arising from stressful situations known as reactive psychosis, or arising from any physical or neurological conditions, or sometimes even schizophrenia-like disorders. They all present with a similar kind of symptoms in the beginning. The commonest differential diagnosis which people like to call is substance-induced psychosis, where cannabis or other illicit drugs are consumed and the psychosis comes just because of that. It is important to realize that here the connection between the substance and psychosis is direct of cause and relationship. It is not a situation where a drug consumption has increased the chances of schizophrenia, but here the psychosis is because of illicit drugs.
It's important, though, when it comes to drugs and psychosis, for people not to completely rely on the fact that this illness is just going to go away. A lot of times people don't understand if it's drugs, why do I need medications? Why do I need treatment then if it's just all going to go away? It's usually not that simple. So it's important to understand that there's a very complex connection between psychosis and substance-induced psychosis. It's important to know which one came first. Did the symptoms come first, or did the drug abuse come first? And to know that usually it's never so simple just to say that drugs has caused this, everything's just going to go away, everything's just going to go back to normal. You still need treatment to address the symptoms that are occurring, and treatment will follow this similar course regardless of where it's come from. So it's just really important to understand that it's not probably just drugs that cause this. It's probably a bit more complicated than this, and it's still going to need treatment.
So as we said that psychosis can arise from other primary psychiatric disorders, like you have depression, mania, or a reactive psychosis, or hysterical psychosis, or transient psychosis, or a brief reactive psychosis, or when someone goes through a huge experience of trauma, or psychological devastation, or adjustment disorder in terms for people who immigrate from one place to another. All these conditions are known to cause psychosis when they are too severe. However, this psychosis is certainly not schizophrenia. It can also arise from either conduct disorder or personality disorder, which is a complex disorder and present in some of the people. It can come from certain medications can cause it. Some frontal lobe or brain tumors or neurological conditions like multiple sclerosis or a physical condition can cause it. So it's important to rule out the secondary causes of psychosis before defining it as a functional psychosis. One of the common conditions is affective psychosis, where a patient is suffering from depressive syndromes and goes on to develop hallucination and delusions and presents with psychosis. There are other non-affective psychoses which are where symptom constellation or symptom profile is exactly like what we see in psychosis of schizophrenia or a schizophrenic origin, and they are similar but they are not the same in their nature and course. Psychotic depression and other psychotic disorders are some of the other conditions. The message that we want to convey is everything with odd behavior, hallucination, delusion, hearing voices, and paranoia is not schizophrenia. However, it certainly is psychosis. So a treatment team or physician need to determine what is the type of psychosis and then plan the treatment. So the question is, how do they confirm the diagnosis? What is the way forward to confirm the diagnosis? The main difference is between a psychosis of non-schizophrenia origin and a psychosis of schizophrenia origin in literature is the duration for which the symptoms have persisted. The DSM, that is Diagnostic and Statistical Manual of the American Psychiatric Society, American Psychiatric Association, which is a classification system used worldwide, recommends a duration of psychosis of at least 6 months to call any psychosis as possible schizophrenia, besides several other criteria. Sometimes the possibility of schizophrenia can be identified during early phases because of the presence of certain characteristic symptoms which are exclusive to schizophrenia. Therefore, the clinical condition, the clinical profile in early phase of psychosis can sometimes give an indication whether this psychosis will develop into a kind of schizophrenia type illness or not. Most of the psychotic disorders are not that severe, they are limiting, and they persist for shorter duration of time in comparison to those psychosis which is of a schizophrenic illness. The starting point would be to frame a working diagnosis, and it is all right to call it an early psychosis or early phase of psychosis or acute psychotic episode, etc. And from there on, the two things are required. One, to exclude possibility of any physical condition, to collect more information which is helpful in framing the diagnosis, and consider other possibilities. Normally, everyone does the urine toxicology test to rule out whether there is substance is present or not. So diagnosis of schizophrenia is confirmed by observing the symptoms of the patient over a period of time. The presence of features which are characteristic, and by following a set of criteria, the diagnosis of schizophrenia is framed. These criteria mostly include presence of positive symptoms, presence of negative symptoms, evidence of decline in social functions, and absence of a drug or alcohol as its origin. So these are the symptom subgroups. We will further elaborate what is positive symptom, what is negative symptom, but because these are the most commonly used scientific terms, we have carried them here as it is.
The term psychosis is from the Greek word psyche and osis. Psyche means mind or soul, and osis means abnormal condition. So the literal meaning of psychosis is an abnormal condition of the mind. We often think about a psychosis as a loss of contact with reality, and that is sort of the signpost of psychosis. Having symptoms of psychosis, though, we remind you, does not mean that the individual has the diagnosis of schizophrenia.
So the exact cause of schizophrenia is not known, but we do have enough information to treat patients. We do know that it is a neurological behavioral disease, which Dr. Shrivastava will talk about in more detail later. We also want to continue to reinforce with everybody that there is nobody to blame for this illness. It's not your fault, it's not your family's fault, it's a medical condition just like any other.
Schizophrenia is a chronic and severe mental illness. The description of schizophrenia since last 100 years has not changed, and it does carry a negative impact when we talk the term schizophrenia. Scientists are struggling with the fact that how would be the idea to change the name of schizophrenia, and I hope it happens in future. However, schizophrenia affects approximately 1% people across the world in every country, in every geographical and cultural society. It affects about 0.7% of world's population. So it's a common disorder, and it cuts across all society and races and religion. Schizophrenia often it strikes people between the age of 16 to 25. However, it does not mean that schizophrenia does not arise after the age of 25. There is a variety of schizophrenia which we call young adult schizophrenia, and the second is middle age, and the third is late onset schizophrenia, which first time appears in geriatric or older people. Men are more likely to display the symptoms earlier than women, and that's one characteristic difference, because symptoms often do not become apparent until young adult. The individuals and their family often struggle to understand the seemingly sudden onset of the illness. There is a component of social deterioration which does not allow people to identify the sudden change. There is scientific evidence showing that schizophrenia is a brain disorder. It is a biological illness. A lot of work on schizophrenia research has gone through. We have now got information about human brain from various sources by doing sophisticated imaging technology, by using sophisticated EEG. And what is known today that the brain structure is different in patients suffering from schizophrenia than their normal population. The ventricles, which is called popularly a water bag in our brains, is much enlarged in patients suffering from schizophrenia, which gives a signal or a clue that the pure brain cells, that is the cortical volumes, are less in quantity in schizophrenia. Various areas of the brain have been known to be affected, like frontal cortex, prefrontal cortex, corpus callosum, frontotemporal cortex, and thalamus. More and more advancement is taking place, and every day this science is advancing, and we come to know role of brain, and we also come to know how these changes are brought about and who are the individuals who are more likely to have the brain changes. There are some overlapping symptoms in psychosis. The common symptoms, that is positive symptoms, affective symptoms, cognitive and negative symptoms. It is not necessary that all patients will have all four symptoms. Only a small percentage of patients will develop all these symptoms, and that is not more than, say, 5 to 10% of the patients. Otherwise, the variety of schizophrenia is decided by the predominance of the type of symptoms. So if the patient has more amount of negative symptoms, it's likely to be called a negative schizophrenia. Clinical symptoms of schizophrenia are the most important one, because these are the symptoms which are obvious to clinicians and other general people. And various aspects of diagnosis are based upon clinical symptoms. It is important to realize right in the beginning that the illness of schizophrenia is a clinical condition. It is not diagnosed based upon a kind of brain X-ray or anything hard investigational tools, but it is diagnosed based upon the kind of symptoms those the patients develop. And as I said, a common way to classify these symptoms are positive, negative, affective, and cognitive set of symptoms. In schizophrenia, we see the changes in individuals' behavior, thought process, concepts, emotional state, the power of judgment, and power of volition. These are the main areas in which the deficiency occurs. The commonest to appear are positive and negative symptoms, like unusual thought or perception, hallucinations, delusions, thought disorder, disorders of movement. Individuals with schizophrenia often hear voices that others do not hear. They believe that others are broadcasting their thoughts to the world. They become convinced that others are plotting to harm them. And there are several other associated symptoms, like sometimes they are acting out on these thoughts and become agitated, they become hostile, become very suspicious, remain guarded, develop fixed paranoid or non-paranoid type of delusions. Often these patients report a type of disorganized thinking, unusual or bizarre thinking, which to others does not make sense. They have difficulty in their social interaction, which is accompanied by impairment of activities in daily living. So the common symptoms which clinicians take into account are seeing or hearing voices and perceiving things differently. These are not there, and others like unfounded fear and suspiciousness. Hearing voices are the core symptoms, what we call it hallucinations. Seeing things, that is visual hallucinations, the things which are not there. Feeling differently, feeling paranoid, having ideas of reference, feeling people are against them, and thereafter behaving in odd ways, making postures, having silly smiles, and being unable to comprehend or become aggressive or violent, restless. In fact, psychosis is called a state in which there is loss of contact with reality. It is really a hard concept to understand. Seeing or hearing things that are not there are called hallucinations, which usually includes false ideas about what is taking place or who one is. Psychotic experience is very distressing. People imagine themselves into various shapes, sizes, and remain confused, have problems of, they have difficulty and distress that the way they think others do not conform to them, and they go through a kind of experience which makes them highly anxious. These experiences are very frightening and distressing. Agitation is a common presentation. We normally see violence and physical aggression in patients suffering from schizophrenia. Characteristic suspiciousness and paranoia in their mental state. Sometimes they have rigid posturing, which that state is called catatonic state, which is seen in a minority of patients. Symptoms like spending more time sleeping, remaining guarded, going through spells of depression, and severe mood changes are some other clinical symptoms of schizophrenia.
You'll often sometimes see increased or decreased appetite. And they often you will see a decrease in their ability to initiate plans or speak, express emotion, or even find pleasure in everyday living. Sometimes there's the absence of emotion and or enthusiasm, and they have a flat affect, which their face can be immobile and have a monotonous voice. They show a lot of lack of interest and show little or no interest in anything anymore. They lack the ability to take pleasure in everyday living, and they have a diminished ability to be able to initiate plans or follow through with plans. They have difficulty paying attention and concentrating, which makes things very difficult for them, and they often can neglect their basic hygiene and their everyday activities of living. So a lot of times that's when you see depictions of people who don't look in good condition. There's a lot of negative stereotyping around that, but that's a part of the illness. Again, it's not a choice that they're choosing not to do these things. It's a part of their illness, and that's what we hope to help them with. You also see social withdrawal. The individual will sometimes withdraw from society, and they may seem to be a loner or isolated from others. Sometimes people will say that happens because it just becomes so terrifying to be around other people and out in the real world. There's all sorts of things that are happening for them, and it can be easier just to retreat into their own world that feels safer to them. So all of these experiences cause people to be extremely fearful and, again, withdraw from others. And they have difficulty maintaining their relationships with others because this is happening. Negative symptoms of schizophrenia are often not obvious. So people with schizophrenia tend to be seen as lazy, depressed, or unwilling to better their lives. People don't understand why they don't want to do things anymore, why they're not taking care of themselves, why they show no motivation to move forward with their life, and they jump to conclusions that these people are just choosing their fate. Cognitive symptoms are often detected only when there are neuropsychological tests that are done. And they can have difficulty forming logical and coherent thoughts. The individual experiences a difficulty staying on track during conversations. So they often have thought jumping where one thought might not connect to another thought, and so they're all over the place with kind of what they're talking and what they're thinking and how it's being communicated to others. They also have impacted speech and writing abilities. So again, a lot of times people will see it as someone's not motivated to do something. They're not motivated to follow instruction or not motivated to follow through with treatment suggestions, when really it's because of all sorts of cognitive issues that are occurring, which is why you're seeing poor outcome or follow through, which often people don't recognize that that's what's happening. It also can interfere with the person's ability to earn a living and to have a normal life. If you have all sorts of this kind of stuff happening, you're not bathing regularly, you're not able to communicate effectively, you're not able to write things down in a logical way, that's going to, of course, impact your ability to work. And then you see people losing their jobs and all sorts of fallout from that as well. So this causes, of course, extreme emotional stress for people. They also can have difficulty recognizing that these symptoms are a part of their disability and not really fully understand what is happening.
The cognitive deficits are the single largest barrier for individuals' social functioning and normal life. And it is now becoming clear that it's about 85% to 90% of individuals suffering from schizophrenia do suffer from some kind of cognitive dysfunction. It is also becoming clearer that this cognitive deficit sets in fairly early phase of psychosis, and sometimes even before the clinical symptoms of psychosis have appeared. And they are becoming and emerging a kind of marker for illness of schizophrenia. The patients do become increasingly withdrawn because they are lost in their own thoughts and disconnect from the social situation. They have poor personal hygiene and have very shabby rooms to live when the illness progresses. In chronic conditions, they develop several posturing, and there is neglect of food and water, and go through severe mood changes of depression or manic type. And in severe depression, some of the patients are known to attempt suicide on their life. Overall, schizophrenia presents with a variety of symptoms, and there is no one symptom which is which can be said to be the marker of the symptom of the illness, and it is diagnosed with a clinical criteria of which consists of all the symptoms that we have described just now.
So we want to leave you with a final thought to think about, to try to put yourself in someone's feet that is experiencing schizophrenia or mental illness. Can you imagine how terrifying it would be for people to question your reality, to question whatever you believed in might not actually be the way it was? It would be terrifying to think that the world that you're living in, the things that you're seeing, what you're hearing, sensing, that all of that could be not real. For instance, what if someone said to you that the sky wasn't actually blue, it was green? Can you imagine how hard that would be for you to accept? It would be terrifying if a bunch of people are telling you something, challenging something that feels so real to you. Of course people don't want to accept that that's true. Of course they're going to fight back and say that that's not true, become angry, maybe even aggressive, or yelling, screaming, whatever the case is, because it's terrifying to think that maybe everything that you believe isn't true, that why would these people be telling you these things when it feels so real to you? So it's important to understand that, because it's normal for people not to want to take medications to address these symptoms. It's normal for people not just to say, okay, you're right, I'm hearing voices, I'm seeing things, everything's not real, because it is real to them. It's just like, again, in A Beautiful Mind, he believed the people he were talking to were real. And for him to accept that that wasn't real, that's devastating, and it's hard for them to imagine that everything that they believe to be true might not be. So it's important to try to remember that type of thing, to put yourself in someone else's shoes and to think of something you truly believe in, and think, what would you do if somebody told you that that belief wasn't real, and how you would respond to that.
In this module, what I'd like to discuss with you is known as early warning signs for identifying psychosis. So either you have taken discharge of your patient and he is under observation back home, or there is an evolving psychosis and nobody has assessed this patient. In both the conditions, we want you to know that what are the signs which can develop into psychosis or psychotic conditions. The first set of signs are in terms of biological functions, and that means a disturbance in sleep, an appetite, appearance of extreme anxiety or panic. The second set of warnings is in the realm of psychological functions, and a subject can have loss of interest, irritability, anger, depression, suicidality, or in terms of social context, the patient can have severe isolation or seclude himself. So these are the symptoms which all of us should, those who are monitoring the patients in the home, should keep in mind. There are some risk factors which have been under context of discussion as to why psychosis develops. And I must state here that despite so much research, the NIMH, that's the National Institute of Mental Health, writes on their website that until the etiology of schizophrenia is established, clear-cut risk factors for development of the disease cannot be identified. Everyone whom we talk, all relatives and all patients, they come up with this idea of what they could have done to prevent this illness and how does this illness arise. So kind of risk factors for schizophrenia can be grouped into three different categories. One set would be those arising from social and demographic characteristics. The second would be the factors which make people vulnerable, or the factors which predisposes a person to developing schizophrenia. And the third would be the factors which are directly responsible for the episode. That means they are called precipitating factors. One way to understand the illness is called risk vulnerability model. What it means is that some individuals are at a higher risk by birth. Once they fall into a vulnerable situation, either socially or psychologically, they develop psychosis. It is important to remember that association between lower social class and schizophrenia in urban conditions, for example, is a classical example that some people are born with the risk and go through adverse life situation. Most of the risk can be classified into two sets, that is genetic risk and non-genetic or environmental risk. And it is important to very clearly understand that for psychosis to appear, there needs to be a combination of both the factors. No single factor, genetic or environmental, can really cause psychosis. The gene-environment interaction is the best possible explanation scientists are able to offer for development of psychosis till date. Some of the non-genetic factors are named as say family factors or environmental factors, the kind of expressed emotions in the family members like negative criticisms and humiliations, migration to a new culture, unmarried individuals, birth complication, and poor social class. These are some of the well-known non-genetic factors which increase the risk of schizophrenia. I would again like to remind that risk factors do not work in isolation. No single risk factors alone is capable of producing an illness of schizophrenia. A possibility has been raised that factors related to environmental condition in lower socioeconomic class can play a role in some subgroups of people with schizophrenia, such as occupational hazard, poor maternal and obstetric care, or high psychosocial stress factors. Unmarried individuals are at a higher risk to develop psychosis and schizophrenia. The factors which make people vulnerable are called predisposing factors. These are genetic factors. The genetic contribution to liability for schizophrenia has been well established and is estimated to be around 60%. Perpetuating factors are the factors which continue to maintain the dysfunction or increase the likelihood of ongoing symptoms. How is this illness transmitted from generations? This is another question which people often pose, but this question remains unclear. Many genes are involved. Schizophrenia is not a disorder arising from one single gene. The question then arises, what do we inherit? And it is firmly believed that we do not inherit the illness of schizophrenia. What we inherit is a biological condition to develop the illness, a biological propensity, a biological sensitivity to develop schizophrenia in a given set of stressful conditions. Genetic factors only increase the chances of schizophrenia. Available data suggests that environmental factors play a definite role. It is not one-to-one transmission that if your parents have schizophrenia, you will definitely develop. The studies of twin studies show that identical or monozygotic twins have a rate of less than 50% of chances of developing schizophrenia. If both of someone's parents are having schizophrenia, the lifetime risk is only about 45%. Children only have an increased chance of developing schizophrenia, and there is no evidence that patients of schizophrenia will have children who will also develop schizophrenia. It depends on the kind of gene-environment interaction that would take place in that person. Only 10% people with schizophrenia have an affected parents, and therefore one need not be frightened about having the illness or having someone's parent as residual schizophrenia. There are several varieties of this clinical condition. Given the heterogeneous nature of schizophrenic disorder, it is also possible that both genetic and non-genetic forms of the disorder exist. That means there could be two varieties of schizophrenia depending upon genetic loading, one genetic type and other non-genetic type schizophrenia. The question of genetic risk of schizophrenia is an interesting one to discuss. It is known to appear in about 1% of general population. It's about 2.5% in the second degree relatives, about 8.7% if in siblings of affected individuals. If one parent has schizophrenia, the chances of the child to develop schizophrenia is about 12%. If both the parents have schizophrenia, the chances of developing schizophrenia is about 30 to 40%. And similarly, as we said earlier, if monozygotic or identical twin has schizophrenia, the second twin has only 50% chance of developing the disorder. There is some role of pregnancy event, but the data is not very clear and impressive. Most of the patients who have developed schizophrenia have a history of events in pregnancy. Family environment also can work as a risk factor. Among the variety of factors are variables such as interpersonal, social, and cultural, and postulated as precipitating factors. The family environment has the best evidence.
So commonly seen risk factors is a family history of schizophrenia and other mental health disorders, for example, bipolar illness, substance abuse, alcoholism, or using street drugs.
It's important to understand the connection between drugs and psychosis. Cannabis is a widely consumed illicit drug. In population of patients suffering from schizophrenia, more than 50% have a history of consumption of cannabis in most of the countries. In academic circles, this question has been whether cannabis causes schizophrenia or cannabis causes only psychosis. And a lot of research has been done, as one can see here. The chances of developing schizophrenia in people who are frequent users of cannabis is very high in all across the world. In one line, if this literature needs to be summed up, it is said that if somebody uses cannabis in the age between 13 to 16 or 17, the risk of developing schizophrenia at the age of between 20 and 25 goes very high. We have seen in our clinical practice and with our experience that if someone who has schizophrenia and continues to consume cannabis, he relapses again and again, and the quality of life becomes poorer and poorer. So to sum up, if we have to develop a model, how does psychosis develop? It would be best to say that if someone is born with the genetic material and he or she develops habit of using cannabis in young adolescents, and then develops and faces an environmental stress factors, that person goes on to develop psychosis, or the chances of developing psychosis are much more. Some substances like chronic consumption of amphetamine and a dose of phencyclidine, these are the potential substances which can very quickly cause psychotic conditions. So these are some of the details of how risk factors operate, what are the common risk factors, what we should be careful about, how we should not worry much that if someone in your family has schizophrenia, so you are definitely going to have it. The $1 million question comes, how do we treat psychosis and schizophrenia? Because the causes of schizophrenia are still uncertain, unknown, current treatment focuses on eliminating the symptoms. And at the outset, let me state that treatment of schizophrenia in 2009 is remarkably successful. There should be no dissuasion or no confusion on the issue whether treatment works. The broader goal of the management is return to social integration and back to life, complete integration in society, so that the person is indistinguishable from rest of the people in society. We definitely work towards this goal, and we often succeed, and often we succeed little less than desirable. Management of schizophrenia is a teamwork. It needs a lot of push and a lot of motivation and part of the treatment team. Several professionals are involved, like physicians, nurses, social workers, psychologists, case manager, and family members. Who, besides them, the most important member of the team is a pharmacist, who help us in taking the decision what to do. Historically, if we remember, every kind of therapy under the sun has been tried for schizophrenia. The standard couch, the psychiatric couch, many believed it's going to be a cure for mental disorders, and it did not. The spiritual therapies, Zen and yoga, fish oil, one-to-one counseling, Ayurvedic, shock therapy or ECT, which has gone into disrepute and re-emerged with great efficacy. Hydrotherapy and herbal medications. So it may be very confusing for relatives to really understand what treatment has worked. All of these have been tried, and what has worked is a scientific treatment. Psychosis does not happen in isolation. You need to be patient. It may be difficult to figure out the extent of problem initially, and therefore, because several other problems complicate it, and therefore you need to give some time to the treatment team to understand the possible complications.
Psychosis can prevent people from functioning normally and caring for themselves, and we've already mentioned that. And if this condition, if it's left untreated, people can harm themselves or others. So how well a person will do depends on the specific disorder, of course, and long-term treatment can control many of the symptoms.
Often this question is posed as to how the examination will be conducted and what kind of tests are done. In treatment of schizophrenia, most of the things go by clinical judgments, and we have a responsibility to rule out whether it is arising from a physical condition. So normal blood work, X-rays, and sometimes if it is absolutely important, then a CT scan can be done. It is routine to do a drug screen for blood and urine to find out if there is an illicit substance present or not, and then to develop a list of treatment targets and develop interventions. The treatment depends upon the cause of psychotic disorder. The successful treatment option is the partnership and cohesion of a team in which everyone contributes. The correct treatment is, which is scientific and evidence-based, consists of three following components: the biological component, the social component, and the third, psychological component. The treatment plan is based on thorough assessment of biological and psychological need. it is increasingly important that family remains as the best companion of the patient to let the patient carry on through this stressful time. The treatment consists of doing it in an early phase, a combination of various therapies, treatment which is comprehensive, which takes care about all the factors which contribute to the illness, and the treatment needs to be continuous without any disruption, because it is seen by the research studies that if the treatment is terminated early, the chances of relapse are very high. And the treatment is multidisciplinary. Several disciplines of psychology, social science, biology, psychiatry, and medicine contribute to walk the patient through this period of time. We need to establish partnership, a meaningful partnership among the resources needed: the hospital, the patient, the families, the professionals, the community, and the support groups. There are several things which are required. We just don't need only one facility of treatment. We need all of these: medication, nursing support, case management, social support, occupational therapy, recreational therapy, cognitive remediation, rehabilitation, spiritual therapy, psychotherapy, group psychotherapy, psychoeducation, marital and sexual counseling, monitoring of side effects, weight management, support from dietitian, regular blood monitoring for lipids and diabetes, and legal support, housing and placement, financial support, availability of medication, crisis services, daycare services, and physical health assessment. There are special programs which should also be available. For example, depression group, anger management groups, healthy living groups, and employment support. Medications form the core of treatment around which other treatments are able to work better. All the drugs with established antipsychotic effects decrease dopamine transmission in the brain. Among available agents, the atypical antipsychotics, that is clozapine, is the most effective one. No antipsychotic medication should be discontinued without talking to the doctor who prescribed it, and it should always be tapered off under a doctor's supervision rather than being stopped at once. Antipsychotic medications have been available since 1950s. They effectively alleviate the positive symptoms of schizophrenia. While these drugs have greatly improved the lives of many patients, they do not cure schizophrenia. Everyone responds differently to these medications. Sometimes several different drugs must be tried before the right one is found. People with schizophrenia should work in partnership with their doctor to find the medication that controls their symptom best with the fewest side effect. The older medications which were in use, like chlorpromazine, haloperidol, flufenazine, etc., are known as typical antipsychotics. In 1990s, a new group of drugs called atypical antipsychotics were developed that rarely produced these side effects. The side effects which typical antipsychotics produce, for example, extrapyramidal symptoms and tardive dyskinesia, that is various movements and shakes. The first of this new drug was clozapine, which is come to be recognized as a gold standard for the treatment. Some of the drugs that were developed after clozapine was introduced, such as risperidone, olanzapine, quetiapine, sertindol, ziprasidone, produce extrapyramidal symptoms and do not cause agranulocytosis. They produce extrapyramidal symptoms rarely and do not cause the agranulocytosis, that is reduction in the blood cells which is caused by clozapine. Medications can cause weight gain and metabolic changes for which one has to be very vigilant and continue the monitoring. People respond individually to antipsychotics. No two people respond similarly. Many people see substantial improvement in both type of symptoms by about 6th week of treatment. No one can tell beforehand exactly how a medication will affect a particular individual, and sometimes several medications must be tried before the right one is found. When people first start to take atypical antipsychotics, they become drowsy, experience dizziness when they change positions, have blurred vision, or develop rapid heartbeat, menstrual problems, a sensitivity to the sun, and skin rashes. Many of these symptoms will go away after the first few days of treatment. But people who are taking atypical antipsychotics should not drive until they adjust to their new medication. If people with schizophrenia become depressed, it may be necessary to add an antidepressant to their drug regime. The common question posed by the relatives is how long the treatment needs to continue. Like any other physical and other chronic conditions, the treatment here as well is long term. Although responses vary from person to person, most people with schizophrenia need to take some type of medication for the rest of their lives, as well as for other approaches such as supportive therapy or rehabilitation if they have been going through multiple phases of the illness. Relapses occur most often when people from schizophrenia stop taking their antipsychotic medication because they feel better, or only take it occasionally because they forget and don't think taking regularly is important. It is very important for people with schizophrenia to take their medication on a regular basis. If they do so, they will experience fewer psychotic symptoms. So the medications are divided into two different groups, typical and newer atypicals, and the common atypical antipsychotics are these 5 that we stated. These can be taken orally or can be taken maybe twice in a day or once in a day. They can be taken injectable, or there are long-acting preparations also available. And the common side effects they go through is sedation, shakes, weight gain, diabetes, and some metabolic conditions which can be talked in length and needs to be monitored on a day-to-day basis. The challenge in medication treatment is to really balance efficacy and safety. It is an art which clinicians know it best, and they are able to do it in most of the conditions to sail through the doses that is required without producing much of discomfort. It's a balance of safety and efficacy that in a given patient, how important is a side effect and how much a person can live with the side effect. However, ideal goal is to avoid any kind of side effect and have maximum efficacy. Having said that, it is prudent to note that ideal is not really practical, and the side effects often are a great problem in compliance. The success on the road of schizophrenia is medication compliance. If you take medication continuously as prescribed, you lead a better quality of life. Often it is a thought, who needs to continue medication for long term or lifelong? How long does the doctor prescribe medication for? After the first episode, medication is usually prescribed for 2 years. There are different guidelines in different countries, but clinically, by and large, it is an acceptable limit. If there are repeated episodes, second or third episode, up to about 3 to 5 years would be a sufficient time. But if a patient has been having a repeated episode, probably the treatment would be for more than 5 to 10 years or lifelong. Most people in schizophrenia who receive treatment get better, recover, get rehabilitated, and get back to society. The challenge is to be able to do the kind of treatment your treatment team wants to do.